Yeah, you'll hear the woman.
Broadcast is now starting. All attendees.
You on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Project of North American Management. I want to welcome and thank you for attending today's webinar here. By providing training on a range of technical. Before we get started, I would like to share some statistics with all of you. The Health Resources and Services Administration uniform. And this graph shows the behavioral health statistics from over 1,300 health center programs across the nation. And as you can see, throughout the years, the number of visits for us, a number of visits for anxiety disorders. For anxiety visits for depression, throughout the years, the numbers have also increased. And there were visits. The graph also shows the patients treated for depression and other mood disorders, number in drug or patients treated for other mental disorders, including drug or alcohol dependence. You can see that the numbers of visits have increased dramatically. This graph also shows that this is the grantees, and as you can see, the numbers have also increased for the same categories. It grabbed my attention the number of visits for depression in there were 60,000 number of visits. And Lingensa is going to talk about this topic. I would like to introduce Linda, since clinical social worker for the National Council for Behavioral Health. She provides guidance and her in primary care and behavioral health on behalf of the expertise in trauma care for assist the CIHS audience years and against work based on her 3-year career. She worked first with the service health services. For ado, I would like to turn the presentation over to Linda. Good afternoon, Linda.
Thank you. Thank you so much, Jose.
Slides.
Okay, terrific, terrific. And thank you so much for having me. And thank you all of you who are Oh, I'm doing that. Sorry about that. Okay, so I wanted to the Center for Integrated Health Solutions, where I work, funded by SAMHSA and HRSA under HHS at the federal government, and the Center for Integrated Health Solutions is a technical assistance center by SAMHSA and HRSA, and sits within the National Council for Behavioral Health, who actually operate the Center for Integrated Health Solutions. And they patient behavioral health and we all have services, many tools, resources, and lessons learned available. This is our website, integration, or information about doing integration. To just preview of our webinar to mention, well, the title of our webinar is Trauma-Informed Care, ACEs Are Not Destiny. ACEs stands for Adverse Childhood Experiences. And what about interchangeable? And what we're going to learn is that other of those mental health stuff as well as and so we're going to talk about what healthcare settings need to know, strategies for organizations. And so in terms of background, I talked earlier than people in the general population, which is statistics. And CARE Act, the triple aim, health outcomes, increase patient satisfaction. We know bidirectional care is really, hopefully, the wave of the future and the way to those, those statistics, and really increase the lifespan of people with serious mental illness. The other statistics, in keeping with the statistics related to trauma, really is that illness have a very high rate of, we could somehow in our work, we can really read definition. And this definition comes to us from SAMHSA. SAMHSA Substance Abuse and brought together a panel of experts. They came up trauma, principles around trauma-informed care, and a definition of trauma-informed approaches that we're going to talk about today. And I think it really helps to clarify. I know in medical settings, often we think about trauma as physical trauma related to accidents and things like that. So here we're talking about psychological trauma. And they came up with the 3 E's. Individual trauma results from an event or a series of events, and that's experienced by an individual as overwhelming or life-changing. And so one of the things about that experience is that it really has to do with the perception of the person. What was that experience like for that person? 2 people may experience the same event, like a disaster, or may live in the same household, but they experience it differently. And so we really need to understand the perception of that person and not necessarily go by what the actual event was. And so we're talking about an event, how it's experienced by the person, and we have to understand that it has a profound effect on that person's psychological development, social, spiritual well-being. And so it's really important for all of us to understand this definition and to share what we know about trauma with others working in our settings. And so there are various types of trauma. This is not an exhaustive list. Certainly, you know, there's child abuse or child maltreatment. There's complex trauma when someone has a series of traumatic events, such as child sexual abuse that may be occurring over time. There's serious accident or illness. HIV would be included in that. And it's not just someone who experiences that traumatic event, but someone who witnesses that event can also be just as traumatized as a person who experienced it directly. So, for example, children who are living in households where there's domestic violence are certainly at risk for experiencing trauma. Significant loss, historical and generational trauma, really important issues to understand and think about when we're seeing people who would be affected by this. And of course, there's natural disasters, political violence. I don't know if any of you are seeing the refugee population, but certainly there's tremendous trauma in those folks. So we mentioned the title of this presentation as having to do with ACEs, and that ACEs are not destiny. And what we're talking about is we have to sort of understand as much as we can about adverse childhood experiences and know that although there's a tremendous impact, we can help people. You know, people can recover and heal from these experiences. And one of the ways we can recover and heal is by creating trauma-informed environments, and we'll talk more about that later. But one of the chief studies that really helped us to understand the prevalence and impact of trauma was the Adverse Childhood Experiences study that was done back in 1998 by Kaiser Permanente along with the CDC. And this is a long-term study. They're still studying the impact of adverse childhood experiences today. And so this information is really important to us in understanding, you know, trauma and its effect. And so what we see here is that there's the impact really starts at birth, and sometimes people would say it even starts before birth, you know, in the womb. But it certainly goes from birth to death, and starts with this adverse experience, and that experience really leads to social, emotional, cognitive impairment. You know, we look at stress and we you know, talk to people who have had these experiences, we can see that it's hard for them to kind of follow and understand what we're saying sometimes. There's the adoption of health risk behavior we see in HIV clients. This also leads to disease, disability, and social problems. And of course, there's early death. And I mentioned that in relation to the population of people with serious mental illness. That really what's underlying, I think, those issues is not just the experience of mental illness or substance abuse, but the underlying trauma. And so what did the study look at? They looked at these 10 categories: physical abuse, sexual abuse, emotional abuse, physical neglect, emotional neglect. They looked at, interestingly, whether or not there was someone in the household who had a mental illness. And so it's important for us to think about the fact that children who are living in a household where someone has mental illness, and more of these, would certainly be at risk for developing adverse experiences, and which leads to mental illness and substance abuse. Whether there's someone in the household with suicidal behaviors, drug addiction, or alcohol addiction, or youth witnessing domestic violence against the mother, I would say, against anyone in the household, and certainly loss of a parent, death, abandonment, even divorce, and incarceration of a family member. And certainly we know that there are high rates of incarceration among certain population groups, African Americans in particular. And so these are some of the things that we've learned from the ACE study. There are many, many outcomes related to the ACE study, but it's really interesting to see that they looked at, their study included 17,000 people, so it's a really large study. And what they found is 1 in 4 people were exposed to at least 2 categories of adverse childhood experiences. 1 in 16 were exposed to 4. 22% were sexually abused as children. And this is a population of people, these are Kaiser Permanente participants in California, mostly middle-class white families. 66% of women experienced abuse, violence, or family strife in childhood. Really large numbers. It's also important to note that there was a strong correlation between the number of adverse childhood experiences and the amount of medical care needed when that person entered adulthood. They found that women with 4 or more categories of ACEs were twice as likely to be diagnosed with cancer. For each ACE score a woman had, her risk of being hospitalized with an autoimmune disease rose by 20%. And ACE score greater than or equal to 6 shortened an individual's lifespan by almost 20 years. Really incredible statistics. These are the physical, behavioral health, social outcomes that are linked to adverse childhood experiences. Certainly high rate of alcohol, tobacco, drug use and abuse, divorce, diabetes, HIV, intimate partner violence, lung cancer, suicide attempts, and certainly self-regulation and anger management issues. And so what happens when someone experiences these adverse events or traumatic events is that really shapes a person's beliefs in relation to their worldview, their spirituality, their identity, how they think about themselves and feel about themselves, and certainly it impacts their approach to services. Whether they use services or not use services is really impacted by their traumatic experiences, and we'll talk a little bit more about that. I want to stop for a moment and check in with you. I think Brendan will do this poll question for us. I think the poll is open. And I wanted to ask, okay, So I wanted to ask you, based on your, obviously you may not have, may not know these statistics, but just based on your experience, what do you think the percentage of people you serve have a history of trauma? 1, 25 to 50%, 2, 50 to 75%, or 3, 75 to 95%.
So we've got results for about 50% of you. I'm going to leave the poll open for about 20 more seconds. So please try to get your answers in.
Okay, Brendan?
We got 66% of answers in. Everybody got an answer, please do so.
I think we can go with what we have right now.
Yeah, all right. I'm going to close the poll and then show the results. Can everybody see the results?
Not yet.
All right, well, while we're waiting for it to show up, we've got 21% of you said 25 to 50%, 44% of you said 50 to 75%, and 36 said 75 to 95%.
Okay. And so most of you thought that it was in the category of 50 to 95%. And I would guess that the people you're serving are probably within that third category, more like 75 to 95%. And so one of the things we talk about really is to use universal precautions. And what we mean by that is, let's just assume that everybody who walks through our door has had some kind of experience or history with trauma, and let's set up our services so that we're really trauma informed, and we're going to talk more about what that looks like later on. Thank you so much for answering that. And so we're going to talk about trauma, mental health, addictions, and stress. And so when we talk about trauma, it's really important to understand that it's characterized by these things. There's certainly a loss of control, because we're talking about these experiences mostly as a child. And so there's definitely a loss of control. There's a feeling of being unsafe and vulnerable. There's certainly a lack of trust, and there's certainly a disruption in relationships. And oftentimes the trauma is at the hands of someone who's in an authority position, like a caregiver, a parent, a friend of the family. And so these issues are really, really important to understand because they relate to how people who have experienced these things are going to interact with us in healthcare settings. If they felt unsafe and they may not know what it feels like to be safe, or if they really have trouble with trust, we have to understand that so that we can work to win over that person, make them feel safe, and create those kinds of trusting environments and relationships. So when we talk about mental health conditions, I mentioned earlier that we believe that trauma really underlies mental health conditions, and Jose mentioned a few of those earlier. We often think about the symptoms that are associated with these mental health conditions as adaptations. So that means that the child who's trying to adjust to, let's say, sexual abuse would have to find ways of coping with that. And sometimes those ways are not very adaptive for them as they get older. And so those kinds of experiences and signs and symptoms may show up as hypervigilance in school or ADHD, and they look like ADHD. But really, when you think about it, what else was that? That kid was really looking for some way to cope with that situation. Mental health conditions such as borderline personality disorder may be caused by serious traumatic stress. Actually, I just came across an article this morning I wasn't able to read yet from a British journal that speaks exactly to this. I mentioned ADHD as well. And so also when we talk about trauma and addictions, Gabor Mate has written a lot. He's a psychiatrist in Canada who's written a lot about the role of trauma and addictions. And basically he says any behavior that's associated with craving and temporary relief, long-term negative consequences, and that a person is not able to give up is the definition of addiction. And he talks about it as early emotional loss is really the template for all addictions. And so what we understand then is the person is really regulation, service, hypervigilance, and that stress, there are these situations where there's ongoing stress. And one of the things we see is that there's an inability to respond, to learn, to process. We may see that when we're doing an intake or when we're having sessions with people where they're just not able to take in the information. And certainly, that would be a sign of someone under stress. I wanted to ask another polling question here. Which of the following is not a sign of trauma? And we've listed 5 areas. So is difficulty adhering to treatment a sign of trauma or not? Missing appointments or showing up frequently, is this a sign of trauma? Ability to listen and follow through with directions? High use of emergency department services? Little to no improvement in health outcomes? I think the poll is open.
It is.
You would choose, okay. If you would choose one answer, that would be great. How are we doing, Brendan?
At this moment, about a quarter of the attendees have voted, so I'm going to leave it open for another 20 seconds or so, give more people a chance to answer.
Okay.
All right, we're getting higher, about 2/3 now. Everybody who hasn't answered now, you have about 10 seconds left.
Thank you so much, everyone.
All right, yeah, I'm going to close it. And the results will be popping up any second now. Can you see them?
No, not yet. Do you want to tell us
Okay.
what
Yeah, 3% answered difficulty adhering to treatment. 8% answered missing appointments / showing up frequently. 51% said ability to listen and follow through with directions. 8% said high use of emergency department services. And 31% said little to no improvement in health outcomes.
Okay, okay. Well, we had the most percentage of people answered number 3. And so, I asked the question in a maybe a tricky way, looking for which one of these is not a sign of trauma. And the answer that most of you gave is number 3. So someone who has experienced trauma, what we're going to see oftentimes is difficulty adhering to treatment, missed appointments, showing up frequently, even if they don't have an appointment. We're going to see difficulty with listening, following through with directions. That's why it's really important to perhaps write things down for folks so that or have them meet with someone, an MA or someone who could go over the directions with them. People with experienced trauma have a high use of emergency department services, And when we see that people are not improving, it's a good thing to start to think about, well, has this person had a history of trauma? And are there areas that we need to focus on other than just trying to keep, prescribing these medications for their heart condition? Are there other things going on here that we need to address? So, thank you. We're going to talk a little bit about what medical settings need to know. It's really important for, healthcare folks to understand that, having an understanding of trauma is just really good medicine. It's really good practice. Many of the issues that we're talking about that someone comes into us with may be actually related to their traumatic life experiences. And we also know that people who've had these experiences are often very sensitive to, especially to reminders in the medical setting that may remind them or may trigger a memory of their early traumatic experience. And so therefore, healthcare settings can actually unknowingly re-traumatize folks. And here we have a list of some of those procedures or events, situations that may actually cause some distress in medical settings, like invasive procedures, certainly gynecological procedures, really knowing and just asking the person when they come in, letting them know what you're going to do. This is really the case for every kind of procedure visit. It's really letting the person know what you're going to be doing, what it's going to feel like, what it's going to be like, and do they have any certain needs or concerns that they would like to express. Could be very helpful. Having someone remove their clothing, physical touch, personal questions. The power dynamics we talked about, trauma as being, related to authority figures, and so that power dynamic of, doctor or nurse with a patient can be very stressful. Being in a vulnerable physical position, lack of privacy, and certainly overt or covert stigma would be very distressing. So we talked a moment ago about triggers in healthcare settings. And when we talk about triggers, we just mean some kind of an external event that causes internal discomfort or distress. And they come in the form of sound, sight, and smells. Certainly one I think that is pretty common is the sight of a white lab coat. Again, this is kind of the representation of an authority figure and may cause some distress. But the sound of a dental drill, loud noises, the sight of the sight or feeling of the X-ray bib, which is really kind of heavy on someone, depending on their experience. That could be very distressing. And of course, there are certain smells like antiseptic odors, excuse me, that may trigger distress in someone. And so just kind of keeping in mind that there are these things in our environment, and and talking to people about how to make their experience more comfortable can really go a long way. So what does this mean for healthcare providers? What it means is that there really needs to be routine screening for trauma exposure, not just for PTSD, but also for trauma. There needs to be screening for other things that are related to trauma, like substance abuse, mental health, suicide, physical health problems, which you're probably all doing. It's really helpful to have some kind of written materials or posters in waiting areas or exam rooms so that there's kind of a message to folks that it's okay to talk about these things in our settings. And I have those kinds of things available if any of you are interested. You either need to provide some services that are going to address trauma or PTSD or suicidal behaviors, or certainly you probably have partner with behavioral health services that you can refer folks to and then follow up with them. And certainly adopting universally adopting trauma-informed practices is another way of, for healthcare providers to address these issues. So I'm going to stop and ask you, this is the question that I wanted you to write into the chat box. Is there one thing you can change in your environment or processes to reduce potential triggers? So after listening to what I was talking about in terms of triggers, is there something that you were thinking about as we were, as I was talking here, that you might want to change? Just one thing, if you could put in, in 1 to 3 words, what you would change in your environment, or maybe related to your intake process, that could reduce potential triggers. If you would write those into the chat box, we'll give you a couple of seconds here, and then Brendan will read to us a few of those. Thank you.
We have one that is limited pre-exposure. Another is comfortable waiting room. Sorry. Yeah, we have limited pre-exposure and comfortable waiting room.
Okay. I'm not sure limited pre-exposure. I'm not exactly sure I understand. But I do want to say that comfortable waiting room is an excellent response and an excellent way to reduce triggers. For example, if you have a waiting room that's really crowded, the chairs are all on top of each other, and people don't have their own space, or it's chaotic, noisy, certainly that can be triggering to people. And so looking at your environment, your waiting areas, looking at the signs, the pictures, those kinds of things can be really, really helpful in reducing negative experiences. So, and I think perhaps the other person was talking about, somehow limiting exposure to these negative experiences. Thank you so much. And so we want to really move to, go ahead, Brendan.
I was just going to read one more. Ensuring patient privacy during patient intake.
Yes, yes, yes. That's a wonderful example as well. I know that there are certain, certain agencies, organizations that really don't have that kind of a stuff, and it's certainly not conducive to people telling us, giving us information that may be very sensitive. So we really do want to make sure that there is privacy, especially during intake, where that's the person's first experience of coming into your setting. I love that response. The other thing is about privacy is, in your exam room, some people might want the door to be closed because it gives more privacy. Other people may prefer the door be ajar because they have trouble with being in an enclosed space. So it's always a good idea to ask people what they're most comfortable with. But thank you so much for those great responses. So I want to talk about what we mean by trauma-informed approaches. And so I wanted to really start with this, talking to you about a paradigm shift. When we talk about trauma-informed environments and organizations, we're really talking about everybody in that setting going through a paradigm shift from thinking about people as having stigma, shame, blame, to compassion, respect, empathy. And it may not be that we're stigmatizing people, but we have to understand that those people who are coming into us may have experienced stigma. Certainly people with HIV and others, they've experienced shame, blame. I was just reading an article talking about Black youth and how, Black youth and even adults that really don't go for medical care. And it is often related to stigma, shame, and blame. And so we want to do our best to shift that to compassion, respect, and empathy, so that they will feel comfortable in our environment and follow through with the relationships and care that they need. And we talk about seeing everything we do through this trauma-informed lens. So when you're in your morning huddles or afternoon huddles and you're doing case reviews, that you really think about, well, has this person experienced trauma, and how might that be impacting their, their ability to follow through with treatment, for example. So some of the principles associated with trauma-informed care are these, and again, the panel of experts Samantha brought together came up with these principles. Safety, how safe is our environment? How safe does it feel? Not only in terms of the physical space, but also the relationship. Do people who come here get greeted in a way that makes them feel welcomed and comfortable? And do they, is the physical environment safe? Is there enough lighting, and does it feel comfortable and secure? So really, and we talked earlier about how safety is disrupted during the event. And so this is a very critical area for us to look at in our environment. Trustworthiness and transparency. Again, trust was broken during the time of the experience or the event, and so we want to really do our best and understand that we need to build those kinds of trusting relationships. So the person may not be willing to take that medicine that you're prescribing right away, but maybe after developing that kind of a trusting relationship, the person will trust the PCP enough or other staff to really follow through with those treatment plans, for example. Peer support and mutual self-help. Having people in our environment who have experienced trauma and other types of adverse experiences interacting with clients and is so important, because they really represent health and well-being and what's possible. And so using peer support specialists, people who have been recipients of services, can be very, very helpful. Collaboration and mutuality, kind of seeing the person as the expert on their experiences and what they need. Empowerment, voice, and choice. Empowering people and showing them that we believe that they can get better, that they have the ability to heal and get well. Having that optimistic approach is so important, and giving them the ability to choose and to have a voice in their care really promotes resilience and is an important principle. And of course, respect for culture, historical and intergenerational trauma, gender. So really being open and aware and responsive to all of these things is so important. Samantha also came up with the 4 R's to define a trauma-informed approach. It's realizing that there's a high prevalence of trauma. It's recognizing that trauma has a major impact across a person's lifespan. And when we talk about recognizing trauma, we're not only talking about recognizing it in the clients we serve, but also in the staff who are serving our clients. It's also about resisting re-traumatization, which we were just talking about, and responding by looking at our environment, policies, procedures, workflows, practices, and settings. The National Council, we've done a lot of work through the National Council around helping organizations do that, create that paradigm shift and that culture shift to organizations that are really much more trauma-informed. And so we came up with these 5 areas. These really pertain to healthcare settings that really represent what it means to be trauma-informed. And so, we're talking here about early screening and comprehensive assessment of trauma. Are you including questions about trauma in your histories, in your medical histories that you're taking anyway? Are you open to patient voice, choice, and collaboration? Are there ways that, kind of systems ways where people are able to give input, not just about their care, but also about the services? Are you looking at training staff and educating staff about the impact of trauma and how to use some best practice approaches or refer to organizations that can provide trauma-specific services. We talked about safe and secure environments, and of course it's always important to collect data on what you're doing and how, what you're achieving, and to celebrate those successes. Trauma-informed approaches in primary care settings can minimize reactions to triggers, improve provider-patient relationships, improve non-adherence, improve show rates and retention in care, reduce overuse of services, certainly like emergency departments and hospitalizations, help people understand the connection between trauma and their health, and connect people with appropriate resources. And so what do we do about this? So now that we have this information, what are some of the strategies we can use to help folks? Well, I wanted to include this quote by Jeffrey Brenner, who says, the patients you can build a relationship with, you can change behavior. And so, that's just, when we talk about trauma-informed care, it's really all about the relationship and building that trusting, caring, responsive relationship. There's a website called ACEs Too High, which has lots of really great information, including the ACE study. It kind of has the instrument that they use and all kinds of information about the ACE. But one of the things that I saw there was this book that a woman wrote. And let's see, the title of the book is long, and okay, I'm not fine. Oh, here it is. So the title of the book is Childhood Disrupted: How Your Biography Becomes Your Biology and How You Can Heal. And basically this woman is talking about her early experiences of losing her dad in a very traumatic way, and her subsequent years of physical symptoms, complaints, diagnoses, operations. And what she says here is, it wasn't until I was 51 years old that a physician sat me down and asked me the most important question of my life, one that would lead me to better health than I'd had for decades. Were there any childhood traumas or stressors that might have contributed to the extreme level of inflammation you're experiencing as an adult? So I think that, kind of sharing the words of someone who, had this experience of being asked about their early experiences is really quite profound. And so this really goes through, I don't want to take up time now to go through each of those domains, but I mentioned earlier a little bit about each of those domains, and you can go back and look at these. It's also, resilience is really important. So individually, what we can do to help people build resilience, help them connect with people in their environment that they trust. As I said earlier, share your optimistic view that they can heal and get well, and help them with coping strategies. Here are also a list of sensitive practices in healthcare settings that you can share with your staff. And in summary, it's important to include questions about past and current trauma when you're interviewing folks and seeing them regularly. Help the person to understand the connection between trauma and their stressors and their current stressors and their previous traumatic life experiences. Ask them if they feel safe. Use posters. Look for opportunities to build resilience. Share what you know about trauma. Use that kind of information in your team huddles and staff meetings, and certainly focus on building relationships with folks. I just wanted to ask this one more question, and I know we need to get to all of your questions. So is there one thing you would do differently as a result of this webinar? Let's just give a couple of minutes, Brendan, because we're running out of time. So is there one thing, based on what you heard today, you think that you can do differently moving forward? So if we could take maybe 2 responses, Brendan.
Sure. Just need somebody to respond.
Oh, I hope you are thinking about some, some ways either that your organization can, like taking a look at your waiting room, or that you might be able to do in your individual meetings with patients. Do we have any responses?
Yes, we do. One of the answers is they're going to be more aware of how their environment affects patients.
Fantastic.
Actually, most people are saying that now.
I love that.
Another great response is I will ask regularly about past trauma in my first visit and then a few visits later.
Oh, absolutely fantastic. Absolutely great. And if you go to the CIHS website, you will see trauma-related resources there, including some screening and assessment tools. So I'm just going to mention some resources, and thank you so much for your responses. I really appreciate that. I really appreciate you, finding this information helpful, and your work with folks, taking that very seriously. These resources, I think, can be really helpful. There's a Sanford Trauma Concepts paper that has lots of information about trauma and trauma-informed care. There's Sanford Tip 57, which also at the back has a listing of screening and assessment tools. NCPTSD has screening and assessment tools as well. National Child Traumatic Stress Network, also funded by SAMHSA, has lots of resources related to working with children. And there's a CIHS website, a resilience guide can be found at the APA site, and ACES 2 High I mentioned earlier has lots of good resources. So I'm going to stop here and turn it over to Brendan and Jose. Brendan?
Yes, just switching over control to Jose right now.
Okay.
Thank you, Linda, for this wonderful presentation. I just want to remind the audience that to please complete the post survey. Your responses are very important because it helps us improve our webinars. Now, if you have any questions for Linda, please submit it to the question box on your control panel, or use the hand raise icon and your line will be unmuted. I got a question, Linda. I got my email, and there is a grantee asking or saying we have patients from different regions in the world, and English is not their native language. What strategies have you found useful when cultural competency is another stressor?
Yeah, that's such a really good question. And of course, one of the best strategies is something like using community health workers, where you are employing people who actually look like, sound like, and know the language of the people who you're working with. That's not always easy to do, but that's really, kind of the best way to reach those folks. One of the resources I'd like to point out too is the idea of cultural humility, using kind of a cultural humility approach. And that is something, we can send that out to you, kind of a link to the people who developed that process. I'm not sure if all of you are aware of that, but cultural humility is really more about kind of aligning yourself with the person and understanding that you are not the expert on that person. And so you really are approaching that person from a humble perspective, where you really want to understand that person better from their, what their experience is like and what their needs are, how best to address their issues. And so, I think using that approach can be really helpful, and we'll make sure that you get the link to cultural humility. There's even a video that you can watch that could be very helpful. Thank you for that
Thank
question.
you, Linda, for the response. Thank you, Linda, for the response. And we are going to make sure that all attendees receive the link. Thank you. Brenda, any questions on your end?
Yeah. What are some examples of data that should be collected to evaluate the effectiveness of new trauma-informed practices?
Right. Okay. Another good question. So, of course, at the National Council, we have developed these tools and resources that are proprietary, but one of them is an organizational self-assessment, where you start by evaluating your organization in those 5 areas that I mentioned earlier, those 5 domain areas. And then, based on that, you would develop a work plan. We also have a performance monitoring tool where you can look at each of those areas, your goals in those areas, and kind of monitor your progress. But I think you can do that without having our performance monitoring tool. I think it's, if you chose even one of those domain areas, like safe and secure environment, and came up with 2 or 3 goals within that domain, you would want to understand, how are we going to know that we've achieved our goal? What is the outcome we're looking for? What is the measurable outcome? Is it that we're going to have fewer chairs in our waiting area, or we're going to paint the walls a different color, we're going to get input from our clients? So you can come up with what that measurable outcome is going to look like, and then collect data on those results, so that you're kind of watching your progress over time, and will know which areas you're making progress in, and then share those results with your staff and with your clients. So I hope that's helpful.
Yeah. Another question that we have here is, are there any strategies for working with communities, or does this work only on an individual level?
Oh, that's absolutely, you are so right. Actually, at the National Council, we came up with 7 domains. We kind of reduced them when we work with healthcare settings, because you guys are so busy. But the area of community, community partnerships is really important in healthcare settings, because a lot of the work you can't necessarily do yourself. You're sending out the specialty care sites and providers, including behavioral health sometimes. And so care. I think those, creating those partnerships and then sharing what you know about trauma and trauma-informed care could be very, very helpful. And I just wanted to go back to the data question, because some of the data that you can collect also has to do with emergency department use. It's hard to kind of connect it specifically to your trauma-informed approaches, but you might be able, you might see changes over time, in emergency department use. In your show rate, that's a really good one to collect data on. And calling missed appointments instead of, and not seeing clients as, what's the word? Uncooperative with treatment, but, having difficulty adhering to the treatment goals. Looking at our language and our signage and things like that could be really helpful.
Thank you, Linda. Thank you very much. Those are great responses. Any other question. Brandon, we can take one more.
Yes, we have one more. There is concern about just screening everyone in the practice using the 10-point ACE scale, as that screen itself may raise trauma emotions and may not be answered reliably. How do you stem against just wanting to get an ACE score on your patients and actually connecting with patients around their trauma?
Right, right. And this is a very common response to asking questions around trauma. See, people understandably don't feel comfortable with it because they worry about a reaction that someone might have. And you know, you can use the ACE as a way of asking questions. You can also use something called the life events checklist or the PC-PTSD, which is used in primary care settings to at least identify post-traumatic stress disorder. But I think what's really important is you talking to the person before you ask those questions and talking to them afterwards. Those two pieces are going to be really important. So how are you introducing this? Letting the person know that I'm going to ask you some questions that are pretty sensitive, and it's going to help us to really understand you better, your experiences better, and you doing education at that point. You're helping them to understand that we know there's a connection between trauma and even physical health conditions. And then once you get the responses to those questions, I think most of the time you're not going to have people falling apart. But what is important then is to help that person. What you can do then to address their concerns is, or their reaction is, how can we make your experience here more comfortable for you? I see that you're upset and this is a difficult situation, but how can we help you to be more comfortable here in our setting, or to address these issues that you just talked to me about, and then talk to them about some resources that you would have to refer them to, and helping to educate them about the connection between the trauma and their physical health or substance abuse, mental health issues is really another way. So you're really doing the intervention as you're asking the questions. I hope that helps.
Great. Thank you, Linda. Thank you very much for all these responses. And if there are more questions, please submit the questions. And we are going to make sure that Linda gets your questions so you can get your response. Please visit our website, www.nchph.org, to get information on the training and technical assistance resources that we provide. I just want to mention the regional symposium that we are hosting November 15th and 16th in Chicago, Illinois. Information on this event is on our website, and I'd like to mention that we are going to have the honor to have Linda presenting a mental health session at our event. So if you want to meet Linda personally, I encourage you to go to her website and register for our regional symposium. You can also join our mailing list and get information on health updates, Medicare, funding opportunities, senior programs, and information about our services and webinars. You can also follow us on Twitter or subscribe to our YouTube channel. And if you have any training or technical assistance needs, please contact any of our staff members, and we are going to be very pleased to help you. One more time, I want to thank Linda for this wonderful presentation. And we need people like Linda to keep us abreast on topics like trauma-informed care. To all of the attendees, please complete the post survey. This helps us to improve our webinars. And if you have any questions one more time or any training or technical assistance needs, please contact any of our staff members. Once again, thank you very much for attending this webinar, and thank you, Linda.
Thank you, Jose and Brendan, and for all of you who participated today.
Thank you.